NAMI Montana, and we're the National Alliance on Mental Illness for Montana, and we're a grassroots organization that supports, educates, and advocates for Montanans who live with mental illness and their families. And we are incredibly grateful to everyone that's joining us today. I'm delighted because we have a really dear friend of NAMI Montana, Dr. Ruth Striegel Weissman. And as many of you know, we have worked really hard over the past couple of years to try to bring mental health research to Montana and bring more mental health research to Montana. And Dr. Weissman moved across the country to our neck of the woods for love, and then jumped right in with every fool's errand that we've been on. She's been on it as well, trying to bring better and different kinds of treatments. And she was willing to get so far outside of what she is an expert in, which is eating disorders. And we are delighted to finally be able to say, Ruth, show us your world of eating disorders, and so we can learn from it, because it's such a critical and dangerous mental illness. Certainly, this is the one that I first learned about from losing a friend with bulimia. So we're so grateful to Dr. Weissman for joining us today, and more importantly, for just being part of the overall family of people working to improve care in Montana. Thank you.
Thank you very much, Matt. And can I get the screen sharing so I can show my slides?
Can you click on the share screen, Ruth, on the bottom?
Okay, let me try. Hold on. And while I do that, thank you very much for that very kind introduction. It's really a pleasure to spend this time with everyone. Can you confirm that you see my slides?
We're all good.
Okay. All right. And let me just do the slideshow function, and we can get started. So before I get started, I just one statement of declaration of conflict of interest. I'm the editor-in-chief of the International Journal for Eating Disorders, and for that work, I receive a stipend from the publisher. And I also want to gratefully acknowledge permission to use some slides from my colleague, Evelyn Tia, who's at Columbia University and in the United States. That's really one of the preeminent centers for research and treatment of eating disorders. What I'm going to cover today are basically answers to three questions. One is, what's the problem with eating disorders? How bad a problem is it? And what works? And I'm essentially doing a 10,000-foot flyover over what is known about eating disorders. And one of my goals is to dispel some myths and hopefully improve the understanding of eating disorders. And speaking of myths, I'm just going to give you a few true quotes. These are things people have said to me. Eating disorders is that stupid thing vain women do. Other people have said, I wish I could catch anorexia nervosa for a while. Or one time I talked with someone and I said, have you ever been diagnosed with an eating disorder? And they said, I should be so lucky. So if we sort of step back and think about that, just imagine you ask someone if they're very depressed or if they're experiencing symptoms of schizophrenia. And I think you would agree, no person would answer back and say, I should be so lucky. So when we think about eating disorders, what's the problem? Well, the most commonly known forms of eating disorders are anorexia nervosa and bulimia nervosa. And one of the common misconceptions is that in the case of anorexia nervosa, that they're basically people who have that problem are willful or stubborn, or people that experience bulimia nervosa are gluttonous and out of control. And the idea of willful stubbornness, for example, goes way back to the 14th century, where Catherine of Siena, who later was elevated to sainthood, who fasted as a form of pursuit of spiritual practice. Her confessors often felt that she was just this annoying, stubborn girl. And people think that bulimia nervosa goes all the way back to the old Romans, which is actually a misunderstanding of an architectural feature of the ancient buildings where big games were held, and these massive entryways, and there's a picture shown here, they were called vomitoriums, and it has nothing to do with to vomit, but rather it was actually the Latin word meant it's a place where people are expelled. Like if there's a huge crowd at the end of the games, they would crowd out of these, and they were called vomitoriums. So it has nothing to do with vomiting. But my point is that the notion of what role culture plays is very commonly debated in eating disorders. And one of the things I hope you will take away from my presentation is that in the case of anorexia nervosa, culture actually has very little role. It's a brain disorder, it's highly genetic, and I'll come back to that point. And there are, in contrast, bulimia nervosa and another eating, so I'm going to talk about binge eating disorder. There is in fact a cultural component, but of course at the end of the day, it's not helpful. In fact, it's silly to try and split culture and biology entirely, because they are intertwined. But in terms of distinguishing the two disorders, that is a major distinction between anorexia nervosa and bulimia nervosa. But thinking of culture, one way where culture does play a role is that eating disorders are highly stigmatized in kind of an interesting twist. They're actually glamorized, and in part that may have to do with that they often get covered in the media as something that the rich and famous or even royalty experiences, in the case here of Princess Diana. And as I mentioned earlier in the quote, they're often seen as self-inflicted due to vanity or attention seeking. They're also trivialized as, quote, slimming diseases, and shown here on the slide on the right, this quite large gentleman wears a t-shirt that says, "I beat anorexia," as though that's kind of a laughing matter. Or on the left is a picture from a billboard that was shown for a while until advocates finally successfully got it taken down, that advertised the television show Friends with this saying, "See cute anorexic chicks." So there, as a culture, we have a real problem with eating disorders, that they're seen, that trivialized and often even ridiculed. So when we think about what is the problem, there is a lot of dimensions to eating that we could focus on. One dimension is simply how much people eat. And in fact, the eating disorder anorexia nervosa, and another one which may not be as commonly known, called avoidant restrictive food intake disorder. A key problem here is that people don't eat enough. Whereas in bulimia nervosa and binge eating disorder, people have episodes of eating too much or binge eating. Another dimension is what people eat. And there is an eating disorder the Brits call pica, we call pica, where people eat non-food substances such as clay or dirt or chalk. And it's often associated with brain dysfunction and disorder, so that it has a strong biological foundation. Currently, people are talking about yet another form of disordered eating, and that is an obsession with eating, quote, healthy or clean food, and some call it orthorexia. It's not recognized as a formal eating disorder, but I'm mentioning it because it gets a lot of play in the media currently. Another dimension of eating that can go awry is the time when people eat. And there is an eating disorder recognized called night eating syndrome, where people eat the majority of their intake very late in the evening or even in the middle of the night. Also, some people think that the motivations for eating may be part of the problem. And you may have heard of the concept of emotional eating, and the healthy counterpart would be, quote, intuitive eating. Emotional eating per se is not an eating disorder. And finally, we could focus on the consequences of eating behavior. And there is the starvation syndrome, which is a well-recognized biological and psychological constellation that is the result of prolonged starvation. It is not an eating disorder. Why? Because people who experience starvation syndrome, they're not getting into this voluntarily. This syndrome occurs at times of extreme food scarcity. And anorexia nervosa, the physical consequence is in fact the starvation syndrome, but unlike anorexia nervosa, people who have starvation syndrome because of food scarcity, of course, that's not, it would be silly to consider that a psychiatric disorder. And finally, obesity, of being a very high weight, is not an eating disorder, it's a physical condition. So when we focus on the question of what's normal eating and what's disordered or even an eating disorder, you can think of a continuum where normal eating, our food choices are mainly influenced by hunger and our preferences for what we want to eat. We don't experience guilt or shame over eating, and we don't have problems eating in social situations. Whereas disordered eating, now we're moving into food choices being more influenced by wanting to be a certain body type, often feeling guilty or ashamed around eating, and avoiding certain circumstances where we can't exert control over what we eat. And then finally, at the extreme end of the continuum of eating disorders, where the food choices now are influenced by goals having to do with wanting to lose weight, or the food choices are influenced by binging and purging behaviors, where people feel profound shame or guilt around food and eating most of the time, and where often social context is avoided when eating. And the answer to what's an eating disorder or this mental syndrome or psychiatric disorder is literally arrived at by expert consensus based on research of patient and community samples. And literally every decade or so, a group of experts gets together for all of the different mental disorders, reviews the evidence, and proposes criteria. So currently, here is the list of eating disorders that are recognized. I'm not going to go through all of them today. I will focus primarily on anorexia nervosa, bulimia nervosa, and binge eating disorder. And in the United States, we use the nosology, the Diagnostic and Statistical Manual of Mental Disorders, and the category of eating disorders, or feeding, in children's cases, we call them feeding disorders, is sort of the overarching definition that they're characterized by a persistent disturbance of eating or eating-related behavior that results in the altered consumption or absorption of food, and that significantly impacts physical health or psychosocial functioning. And we just had the Super Bowl, and many of us hopefully assembled some really nice food to watch the game. And this is one of those circumstances where our eating may get out of control. And if that happened and you enjoyed lots of food in that occasion, that is not an eating disorder because it's not persistent. Similarly, another culturally sanctioned time when we collectively overeat or even binge eat is Thanksgiving. Again, those are temporary situations. So the key here is that the behavior has to be persistent, and it has to be associated with impairment of health or psychosocial functioning. So the eating disorders I'm going to focus on, anorexia nervosa, bulimia nervosa, and binge eating disorder, they all have this element of disturbance of eating. In the case of anorexia nervosa, under eating, not eating enough. And in the case of bulimia nervosa and binge eating disorder, periods of overeating with a sense of loss of control. And the only distinction between bulimia nervosa and binge eating disorder is that in bulimia nervosa, there also are efforts to counteract the impact, the caloric impact of the overeating by purging. And as an aside, I want to mention there is another eating disorder recognized called purging disorder, where the person actually doesn't have binge eating episodes, but they do practice purging behaviors such as vomiting or using laxatives or other forms of purging to maintain a slim body. And then the second dimension of eating disorders is disturbance of body image, which is a defining feature for anorexia nervosa and bulimia nervosa. The example is weight and shape are so important to the person's sense of self-worth that they are taking primacy over other important life goals. So a clinical example is, for example, I had a patient who was a freshman at Yale who, after her first semester at the university, told me she was now going to take a leave of absence from the university because she had gained a few pounds and she felt she needed to lose that weight. That was more important than staying at this elite university for her education. And finally, disturbance of weight, interestingly, is only a symptom and defining criterion for anorexia nervosa. It does not factor in a diagnosis of bulimia nervosa or binge eating disorder. And then I earlier mentioned this very wordy name, avoidant restrictive food intake disorder. I want to mention it. It was introduced new in the DSM-5, and it's actually on the face of it may look similar to anorexia nervosa, except people who have this problem, they do not have body image disturbance, but in many other ways, they look similar to those with anorexia nervosa. It's can occur across the lifespan. In young children, it's often actually the consequence of having been born prematurely and been fed through tube feeding, which can be painful. And so these children may have learned that eating, the actual act of eating, is aversive. And so they avoid eating because of that problem. There are other examples. Some people in that have this particular syndrome may have sensory aversion to food, smells, tastes, textures, and so forth. And this syndrome can have very serious health consequences of nutritional deficiencies. So one case I was familiar with was a young man who would eat literally nothing but French fries. That's all he ate, and it resulted in very serious nutritional deficiencies. So there's more attention now to this particular problem, in part because we have many more children that are born prematurely and may present with that. So I gave you some examples of what eating disorders are. Now I'm going to switch to how much of a problem are they really? And when we think about the burden of suffering from any health or mental health condition, there's a number of parameters that get taken into consideration. One is simply how common a problem it is. So when we think of what's happening right now in terms of health, let's think of COVID, for example. We realize it's a really big problem because it's actually very prevalent. It's also a really big problem because of the health impacts. And so for any disorder, we look at how common it is, What's the impact of health and well-being? What's the impact of family or social groups or society at large? And in eating disorders, for example, if you have a family member that suffers from this problem, you may realize it has profound effect on your family life. There may be fights at the dinner table over a person not eating enough because the family may desperately try to get them to eat. Of course, there are the costs of having to get involved with healthcare. And at the cultural level, suffering may also be a function of how much the disorder is stigmatized or arising from health disparities. Now, let me get back to the question of prevalence for a moment, and this is kind of a side note. In the United States, we track all kinds of health problems to figure out what the burden is on the individual and on society. And an example is tracking obesity. And shown here in yellow is the state of Montana, and we're doing pretty well. We don't have that high a rate of obesity compared to other health conditions. So we track that problem. We don't track eating disorders. The closest we get to it is in the Youth Risk Behavior Survey, which is another, this actually gets done biannually, where we look at various health-related behaviors or problems that our children might experience. And there's literally only one question that has any relationship to eating disorders. It's actually worded negatively, not trying to lose weight. So the symptom would be trying to lose weight. And shown in blue are the data from Montana, and you see overall boys and girls combined, about 41% do try to lose weight. And we see a sex difference in that girls are much more likely to pursue this behavior than boys. And of course, just trying to lose weight in of itself is not a symptom of an eating disorder. There has to be other, it's not an eating disorder, there have to be other symptoms. But my point is, in terms of prevalence, we actually don't do a good job in the United States of tracking what's going on. But piecing together from a number of different studies and the occasional nationwide study, we know that the prevalence of eating disorders varies in part by diagnosis. Anorexia nervosa, really rough estimate, is a lifetime prevalence of 1%, so 1 in 100 people in the population. Bulimia nervosa and purging disorder, 2%, and binge eating disorder, 3%. So compared to some other mental health problems, these are not that common. You know, depression, for example, would be much more common. Prevalence also varies by sex, so women are much more likely to have eating disorders. In fact, in anorexia nervosa, it's thought to be at a factor of 12. So for every 12 women or girls, there is one man or boy. And these disorders are most common in young adulthood. In fact, the age of onset curves tell an interesting story. If you look at the x-axis down here is age, and you see that eating disorders, these disorders tend to kick in at around 10, and they keep going up until 20. And then for anorexia nervosa, which is the red line, onset basically stops. I mean, there's always exceptions, but by and large, if a person has made it to their 20s, they're not going to develop anorexia nervosa. In bulimia, you still see some continued onset, but certainly by 40, the curve is flat. There are no new cases. Binge eating disorder keeps going up. And epidemiologists are interested in these onset curves because, well, for two reasons. If you want to prevent it, it gives you a sense of where to intervene. And also, if you think about, well, why do people develop those problems? You can sort of say, well, for anorexia nervosa and bulimia nervosa, the action is somewhere here between 10 and 20. And what's happening in the person's biology or in culture that pushes the onset that seems very developmentally distinct, whereas with binge eating disorder, there may be other risk variables that continue on. And I'll come back to risk in a moment. So in terms of prevalence, I told you how many people typically have that, more women more than men. Now in terms of severity or impact on health, eating disorders are actually very severe in regards to the impact of health. For anorexia nervosa, for example, the standardized mortality rate, I mean, it doesn't get worse of an impact than death, right, is 5-fold higher in patients with anorexia nervosa than compared to age and gender matched samples. These are also disorders that are very hard to recover from. So in anorexia nervosa, even as far out as 20 years past treatment for people who have been treated, only about 40% achieve full recovery from the disorder. Mortality is also elevated in bulimia nervosa and binge eating disorder. About 20% of anorexia nervosa deaths are due to suicide, and suicide is also a major driver of premature mortality in bulimia nervosa and binge eating disorder. And in part, we may understand that in part because these disorders also have very high psychiatric comorbidity, particularly depression. I'll show you a couple other examples. At least 70% of individuals with an eating disorder have at least one other psychiatric comorbidity. Health-related quality of life is lower. Among the health problems that we see in eating disorders are infertility and obstetric complications in women. Poor dental health is another very important problem. And I mentioned those two because when you think about who might detect that someone has an eating disorder, OBGYNs are certainly on the front line for women. Dentists, more generally for all people, are actually among the healthcare professionals that may be the first to detect that a person has this problem. And in terms of psychiatric comorbidity, this really runs the gamut. In anorexia nervosa, anxiety disorders are very common, as are mood disorders in all eating disorders. And then for bulimia nervosa and binge eating disorder, attention deficit hyperactivity, substance use are common, and across all eating disorders, personality disorders, or adjustment disorders. And in terms of the physical health, eating disorders really affect all body systems. The impact on health services, the financial impacts, and caregiver burdens are very substantial. There's research that shows that the age-adjusted cost of the treatment for these disorders are comparable to another severe mental illness, schizophrenia. Similarly, the caregiver burdens for family equals that of individuals with severe mental disorders, such as psychotic disorders. And another issue that's very concerning in eating disorders is that they are associated with curtailed educational attainment. And it makes sense when you think about it. Many of them start in adolescence, and adolescents that have to take out time for treatment may fall behind in school. And educational attainment, of course, is very strongly tied to income. So eating disorders have been shown to have a lasting adverse impact on people's earning potential or the types of jobs that they get. And in the work that I've done, one of the things I've been very interested in and have done work to mitigate is that there is a paradox that people with eating disorders, on the one hand, they don't receive treatment for their eating disorder, and yet they show up in healthcare. They are have higher health services used than people without eating disorders. So there's sort of this paradox. What's going on? They're going for treatment, but they're not being treated. And if so, they show up in primary care. Here, this data slide shows that this is based on a study where they looked at people who were diagnosed with eating disorders. Then they went back in time and looked at the health services record of those patients 2 years before they were diagnosed. And you see here across a huge range of medical problems, from infections to, of course, mental disorders, circulatory disease, muscle problems, poisonings. In all these categories, they had a higher chance of already having received treatment than you would expect by chance. And then on the right-hand side, 3 years after they were diagnosed with an eating disorder and presumably received treatment, their service use across these various different health problems were still elevated. So the point is, A, people with eating disorders have all kinds of health problems, and they do go into receiving care for those problems, but apparently aren't being picked up right away. And these multi-system health problems are persistent. So all of this hopefully has convinced you now that far from being problems of vanity and frivolous and silly, and we shouldn't care about them, they are very severe, very burdensome to the person who has them and to society. And this is a very busy poster that was put together by a company that did an economic analysis for eating disorders in the United States that was published. The report was published last June. That shows that when you factor everything in, all of the costs, the financial impact they calculated was almost 65 billion of annual costs from eating disorders in the United States. So one of the things one might, and the idea is, if one thing, there are two major things that we can do to address this problem. One, of course, is prevention, and the other is, of course, effective treatment to mitigate the effect, to shorten the time people suffer, developing effective and cost-effective treatments to reduce the financial costs and so forth. And when we focus on, well, why are we not treating these problems? There's a lot of blame to go around. This cartoon says today we're going to decide who to blame. We could look at, and hopefully we're not framing it in a blame framework, because that's totally not helpful. But we can look at opportunities. Where are the points of entry to improve the situation? And when we look at the person, one issue is that there is lack of mental health literacy. And again, those of us who work in the mental health space, we know that doesn't just apply to eating disorders. That's true for suicide. That's true for lots of other mental health problems, that people aren't aware that there are problems, that these problems have solutions, and they may not know where to go to get help. So that's one issue. Another is that there may be in eating disorders a lack of motivation or insight. People may not recognize that what they're doing is actually a disorder or a problem. And in fact, when you take someone who experiences bulimia nervosa, they may very much want to no longer binge eat. They don't like to overeat, but they may want to hang on to their ideal of being very, very skinny. And so they're afraid if they go into treatment, the therapist, quote, will make them fat. So they lack motivation to go to treatment because they don't understand, of course, that's not the treatment goal, but that's their fear. And so rather than blaming them for that fear, we have to figure out an empathic and understanding way of helping the person see what treatment really can accomplish. When we focus on the therapy, the quote problem of blame here is multifold. In part, people may not go into treatment because it's too expensive, it takes too long. They may feel it's not sufficiently effective. So there's aspects to the treatment that may become a barrier to people trying to seek it out. On the healthcare provider side, we know that they may not they may not have suitable knowledge to actually detect the signs and symptoms that the person in front of them has an eating disorder. And so they're treating the presenting problem without asking some additional questions. And finally, on the healthcare policy side, certainly in the United States, we still lack services for people with eating disorders. We know we lack services for people with mental disorders. In fact, the state of Montana is a mental health service desert. There's just not enough services, let alone for eating disorders. And there are other undue access barriers, such as costs and so forth. So I've told you about the burdens and the access to care, but let me just go back to this question of, well, why do people have to get these problems in the first place? And again, the myth is that these are cultural disorders, and there's only a part of that to that. The myth is also that they only affect the young women, the rich women, and so forth, the movie stars, that kind of thing. Well, research has shown us that these are, quote, democratic disorders. They impact people across the socioeconomic spectrum, across racial and ethnic groups, and they're increasingly global. The risk is multifactorial, meaning there are risks from biological, psychological, and social domains, and I'll come back to that in a minute. And they're mostly non-specific, and that's not surprising given that these disorders are very comorbid with other mental disorders. So I mean, most risk factors are not unique to eating disorders. They also apply to other mental disorders. And I already showed you that, however, they seem to be quite developmentally specific. So in terms of this cultural piece, we definitely do have this clash of beauty ideal versus a toxic health environment. And just one quick example. So here's a advertisement campaign for eyeglasses. And the model that's featured here is very, very skinny. And people rightly react to this with saying things like, you couldn't at least buy this model a sandwich, for God's sake. But more deeply, the concern here that people have is that there are people looking at these images and they're learning the lesson that being skinny means being successful. And that's actually a very important cultural signal. So skinny doesn't just signal beauty, it also signals success and wealth. So there certainly is that piece that our culture upholds that, and that this ideal occurs actually in a context of a health behavior environment that's quite toxic, both in terms of what we're encountering in the food environment, and I'm sure you're well familiar with the increase in serving sizes. So what you would have been served at a McDonald's or some similar fast food place in the 60s, the typical portion sizes are, at least a third of what they are now. And interestingly, same is true, by the way, for drinks, in this case shown for the size of wine glasses. And why this is relevant is that we are actually wired to respond to portion size, and we overeat when presented with larger portions. And it even influences things such as our cutlery and our plates and cups. If we present food in larger containers, we tend to eat more of it. So we live in a culture that's basically driving excess intake. And if you are concerned about your physical appearance and want to be thin, then this kind of pushes you in a bad direction in that regard. However, that's only one piece. So let's look at other environments. We know that there are risks from interpersonal environments. So children who are exposed, who lose a parent to death young, or who are separated over extended periods of time from their parents, perhaps the parent is hospitalized for a long period of time, separations like that. We know that's a risk factor for eating disorders as it is for other mental disorders. Also, history of physical or sexual abuse or neglect. So adverse childhood experiences are risk experiences for eating disorders. Now, back to the biology and to my point that anorexia nervosa stands out here in particular, there is actually very strong evidence that anorexia nervosa is a biological disorder. I'm showing here a complicated slide, but I'll walk you through it, of a fairly recent genomic study where these researchers looked at the scanned for genetic aberrations in a very large, almost 17,000 cases of anorexia nervosa, a large sample compared to an also very large sample of controls. And they looked at the genes of these individuals to see where there were aberrations and disturbances. And as you can see on the top right-hand side, there are problems identified in genes regulating or associated with major disorders such as depression, schizophrenia, anxiety disorders, and they're all associated with anorexia nervosa. But interestingly, here on the left, you see the analysis of genes regulating metabolic conditions such as diabetes, for example. Individuals with anorexia nervosa actually are protected. They have a profile associated with low risk for these disorders. In fact, the good cholesterol genes involved there are on the positive side. And then again, down here, obesity, weight-related problems, individuals with anorexia nervosa are actually protected. So the researchers concluded that the genetic architecture of anorexia nervosa mirrors its clinical presentation, meaning people are very skinny, they don't have a history of obesity, they don't become obese, notwithstanding their fear that they'll eventually become obese. They have very high rates of other mental disorders, but they have their genetic architecture shows significant genetic correlations with psychiatric disorders, physical activity, and metabolic and anthropometric traits, leading these people to conclude that anorexia nervosa is a metabopsychiatric disorder. So it's kind of an interesting, commonly not well known understanding of anorexia nervosa. So I want to now sort of zoom ahead and tell you a little bit about treatment, because I know I'm coming to the end of my talk. And basically, what do we know about, so here is the treatment hierarchy. If you have a problem, you might try a little self-help first, and then move up the ladder to guided self-help, time-limited therapy, all the way to long-term care. Most of what we know from the research is based on people having tested time-limited therapies. And in eating disorders, the overall goals, of course, are medical stabilization, nutritional rehabilitation, normalizing of the eating behavior, and then also psychosocial treatment or intervention. In anorexia nervosa, the take home for you to take is twofold. One is behavioral or broadly defined psychosocial treatments are the mainstay. There are not medications that have been found to work specifically for anorexia nervosa. That doesn't mean people won't get pharmacological treatment, but they're usually targeting problems such as anxiety or depression. But unfortunately, as of today, they're not really evidence-based on large trials, medications to treat the core symptoms of anorexia nervosa. For adolescents, the standard of care is family-based therapy. It's very important to understand this treatment doesn't imply there's something wrong with the family. It's not blaming the family. It is engaging the family and rallying the coping skills that the family has to support the patient in his or her recovery. And in the early phases, the parents take over the feeding of the patient. and are helped to normalize that. In adults, as with adolescents, across all these approaches in the treatment of anorexia nervosa, weight monitoring and nutritional restoration and meal planning are absolutely fundamental, must happen. And then there's cognitive behavior therapy is a dominant model for adults with anorexia nervosa. And the Maudsley model is essentially a variant of the family model for children. One thing that's very important for everybody to understand in anorexia nervosa treatment, that if in the acute treatment phase, if we're not patient enough with treatment to achieve a certain level of weight restoration, the risk of relapse is extraordinarily high. So shown here is if the top line, these are patients that when the intensive treatment ended, their weight was still very low, of a BMI of about less than 16.5. So they're still very underweight. And over time, you see that they have a very, very high rate of relapse. Compare that to the lowest bar graph here, where BMI is 18.5, that's normal weight. Relapse still occurs, it's about 15% here, but it's much, much less common than if the patient is sort of let out of treatment prematurely in regards to weight restoration. And for advocates, this is such an important point because oftentimes insurance companies will push therapists and families to move to discharge, for example, from inpatient treatment before that critical weight restoration has occurred and the patient is really set up to fail. In bulimia nervosa, there is a role, and binge eating disorder, there is a role for pharmacology. Fluoxetine is the FDA-approved treatment for bulimia nervosa, and in binge eating disorder, listing dexamphetamine has been shown to be helpful. But the bottom line here too is that psychotherapy is the recommended first course of action. And the psychotherapy model in both bulimia nervosa and binge eating disorder basically goes like this. The person gets into the problem because they're really worried about their weight and shape. They employ very strict dieting rules, which gets them ultimately into binge eating. And binge eating then leads back to more concerns about their weight or shape and low self-esteem. People hate themselves, they're embarrassed, they develop mood distress, which either in bulimia nervosa may lead to purging, or in binge eating disorder, just more binge eating because the distress leads to overeating. The treatment focuses on helping the person get a sense of what they're doing, what the circumstances are, where their eating goes awry, and intervening at that point. And I'm not going to go through the specific steps because I'm running out of time. But basically, for these disorders, there's strong evidence that cognitive behavior therapy works. Self-help approaches of that model work. There are apps that have been developed that help people in their recovery, and psychotherapy may enhance medication treatment. And there's a large literature that people can consult of how these treatments work and that they work. And finally, my colleague Evelina Tia sent me this link that I very much recommend to you. They've developed, so instead of this 10,000-foot course that I just gave you on eating disorders, they've developed a free 6-session course for people interested in learning about eating disorders that you can access via this link that's shown here. And with that, I'm going to stop and leave a little time for questions.
Ruth, that was excellent. Thank you so much. What a great introduction to eating disorders. I guess I'll start with the first one, just because I got the mic. How many people, I guess, is inpatient treatment highly likely for this condition, or you know,
That's a really excellent question. So in anorexia nervosa, a high percentage of patients will need to be treated inpatient, or I shouldn't even say with percentage. If let me answer differently. If the weight loss has progressed to the point that the person is medically unstable, inpatient treatment is necessary. So the question becomes, how early is the trajectory interrupted? And unfortunately, in a high percentage of cases, the trajectory is not interrupted quickly enough to avoid inpatient treatment. So that's part of the answer. The research data show that about 20% of anyone who ever has anorexia nervosa is being hospitalized. So that doesn't sound like a high percentage of all of the cases, but when the illness progresses to the point that the person is so low weight that they're medically unstable, they do need to be hospitalized. Now, we also do know that if you have a therapist that knows how to treat this disorder, and the setup is that the patient can be seen regularly, more than once a week. So if there is a lot of wraparound and intensive outpatient care, it is possible to manage the disorder in an outpatient setting, even if the person is very, very underweight. But it really does mean very regular monitoring and access with sort of the fallback always available of putting the person in the hospital if that's needed. In bulimia nervosa, a majority of cases can be managed in outpatient circumstances. Although again, there too, that there are patients who are so dysregulated medically that they may have such low potassium levels and so forth, or they may engage in such self-damaging behavior in terms of very high levels of purging that their health is just so precarious that to take them out of the environment where they have still control of their own behavior is necessary.
Okay. Thank you. And we did get a question in the chat about what that link was. It's Prepare ED, and was it?
Put it back up here. Can you see it?
What's the?
Oops, my screen is, my pictures cover here. So it's prepared.nyspi.org.
Excellent.
And I can send that to you too, if you want, Matt. And I can't put in enough of a plug to this group at Columbia. And by the way, cost is always such a barrier to treatment for anorexia nervosa. And Evelyn Attia runs a research unit that has federal funding and state funding where they can treat patients, even if the patient cannot pay any toward their treatment. So I often refer people to that service if inpatient care is necessary.
Do they take patients from out of state?
Yes.
Ruth?
Yeah.
Okay, great.
Yeah.
Yeah, we've had a lot of luck referring people to Columbia overall. I know one of our most difficult veterans cases just had a great resolution through Columbia. Oh, all right. Are there any more questions for the chats? Please type them in. Okay, so how can someone find information on night eating disorders?
Oh, well, in this day and age, Google it. So night eating is an interesting one. The concept's been around since 1950, believe it or not. There was an obesity expert, Mickey Stunkert, who introduced this notion. In fact, thought it was more of a problem than binge eating disorder. And basically, as I said, it involves awaking during the night and eating. And there's still a lot of debate whether it should be distinct from the other eating disorders. The treatment is very similar to bulimia nervosa or binge eating disorder, which focuses on regulating your eating patterns taking efforts not to eat at night, because like any habit, once you, even you and I, if we started to get up at 3 in the morning and ate something, over time, we would all want to eat in the middle of the night. So breaking that chain of behavior is part of the care, the treatment.
Excellent. So do we have any more in the chat bar yet? I'm not very good at scanning these. I'm sorry. So Ruth, have they done any research on TMS and eating disorders? I know that they're starting to look more at
Yes, there are
obsessive compulsive
some
disorder.
studies. Yeah, there are some studies, and it does seem to have a benefit. The ones I'm familiar with have focused on anorexia nervosa, but don't quote me on it. It could be that they've also now been tried with bulimia nervosa. They're still considered experimental. So in terms of evidence-based care, they would not yet fall into that category, but that doesn't mean there isn't merit in pursuing that as an option.
Okay.
And by the way, one reason why the treatment research in anorexia nervosa is so challenging is because the typical treatment involves randomization. And when you have individuals that are very medically unstable, it makes it very challenging to do these treatment studies. Because you can't just sort of say, oh, we'll wait, or we'll do some other minor intervention. So it's just very challenging to research in that area.
Excellent. So we had a question in the chat bar. She wanted clarification on the slide with cognitive behavioral therapy. She said it looked like it was not helpful with Binge or with BET.
No, here, I'm sorry that I rushed through that. It's not helpful. So one of the issues with binge eating disorders, often patients presenting with that problem are overweight or experience overweight or obesity, and want that as a treatment goal to lose weight. And the treatment does not seem to impact weight. It does help with the eating behavior. But so if people go into CBT, they may need to take other steps if weight loss is medically indicated. And I'm not saying people need to lose weight. I'm just so that was the point on that slide, and I rushed through that.
Okay. And we had a really nice comment from Dennis Nyland in the chat box. Excellent presentations. So much more information out there and better understanding. 20 years ago, there was so little information, and it was so difficult to help a loved one. Thank you.
Very true. Yeah, thank you for the nice comment, and that is so true. My personal background is I have a sister with anorexia nervosa, and she has had the disorder for 50 years. When she first started out, there was basically no treatment, and believe it or not, in her entire life, she's not had treatment specifically for her eating disorder. So, you know, it's we've come a long way, but there's still people out there that have experienced this devastating problem and still are not accessing care. So there's a lot of advocacy work still to be done.
Okay, and Colleen, can you ask that next question? I'm not seeing the one that you're seeing.
Okay, so there's a question in the question box out. What do you recommend for first steps for a young child who's 12 years old who seems to be exhibiting some signs of anorexia?
Well, the first recommendation is definitely to go to the primary care provider and raise those concerns with that person, and ask for recommendation for a specialist if the problem persists. So definitely not waiting for weeks and weeks, seeking care immediately. And if that provider is not able to tap into resources, there are excellent advocacy organizations that have referral networks, such as the National Eating Disorders Association, NEDA. NAMI, I'm sure, has referral information, and to then seek care with someone who has expertise in eating disorders.
Excellent. So I see one more question here, and this will be the last one, and I'm trying to rephrase it quite right. It's talking about vegan eating strategies, and they're interested in it for heart disease, but as a treatment for heart disease. But I guess I'm just wondering about the relationship between people doing veganism for health and if it could end up triggering eating disorders.
Yeah, that's an excellent question. And we know that people who restrict their diet for any reason are more at risk for developing disordered eating. Anytime we get into very rigid rules about eating may increase risk that then, we start having a problem with eating. But being a vegan or vegetarian per se is not a problem. It's once you sort of make it a religion and you get very rigid about it, that can set you down a bad path. And for some people, they go into veganism or vegetarian diet really as a cover for restricting, in which case then that is a problem. So it's not the diet per se that you pursue. Eating healthfully, of course, is good. It's what are your reasons for why are you getting into that, and are you taking it to such an extreme where the problem arises?
Oh, well, that's excellent. Dr. Weissman, thank you so much, Ruth, for this presentation. It was really helpful. I can tell you that there was a lot of things that we haven't seen just in, just the daily immersion. It was really wonderful. And we're so grateful for everything that you're doing to try to improve mental health in Montana.
Well, thank you for having me. Thanks very much. And thank you to you and NAMI for all the work you're doing.
Oh, thank you. Well, try to stay warm, everybody. It's going to be a cold week. So thanks, everyone.
Bye.
Thank you.